All right, welcome everyone. I'm Ross Prager. I'm one of the hosts of HCP Rounds, joined by my friend and colleague, Dr. Kiran Rikhraj and Dr. Eduardo Argaiz, who you guys know very well. We're going to be talking all about the VTI. Now, Dr. Kiran Rikhraj, she is an emergency physician. She completed an ultrasound fellowship, actually at Western, where I work, and which is where we kind of hung out. But we were also medical school friends back in the day as well. So Dr. Rikhraj has done it all, and she's going to be kind of sharing some of her experiences and learnings with the VTI, far beyond the basic. And so we're really happy to have you, Kiran.
Thank you so much. Thanks for having me, Ross and Eduardo. I'm really excited.
Nice. And you also have a YouTube channel as well that covers kind of hemodynamic ultrasound. What's the name of your YouTube channel?
So it's called Hemodynamic Us, so Us for ultrasound. I have a couple of videos on VTI, the technical considerations, and a bit on diastology as well. And I'm going to be posting more as well. So definitely check that out if you wanted more information after this screencast.
Sweet. All right. Well, before we start and dive into the rounds, we do have to just kind of talk a little bit about our sponsors of HCP Rounds because we appreciate them being able to make this happen. And so the first is our sponsor, FlowPatch, or FlowSonics, who produce FlowPatch. And this talk, we're going to be speaking about VTI, which is a surrogate of stroke volume. But it turns out there's other surrogates of stroke volume as well. And one of them is actually corrected carotid flow time, or CFT, of the carotid Doppler. And what it does is when you get a VTI tracing of the carotid, you can't just integrate it and get a stroke volume. And you're going to see why that's the case when we start talking about PW versus CW, because they're using continuous wave Doppler. But it turns out that if you look at the systolic time relative to the cardiac cycle and then multiply it with some math, that's actually a pretty good surrogate of stroke volume. And most importantly, it can be used to track changes in stroke volume over time. And so we thank FlowSonics and FlowPatch for being one of our sponsors from day one here and supporting this podcast here or webinar or whatever we are. The next is going to be a shout out to something that I'm working on called Resub. And it's a tool that helps you automatically format your manuscript really for any journal in minutes. And so the idea is that instead of you having to go through, read all the reformatting instruction, you can just type in a journal, choose an article type, and then we essentially automate the rest of it. Anything like checking for word count limits, statements, taking out tables, figures, anything like that. And our hope is that not only just with manuscript formatting, but throughout the research lifecycle, we can help researchers become more efficient and more productive. And we've been fortunate to have researchers kind of using Resub worldwide. And if you're interested in checking it out, we have a discount for everyone here at HCP Round. So just check us out at resub.app. And with that, let's dive into the VTI. And so when in my role as a POCUS educator, when I teach ultrasound, the first thing that I teach beyond core lung ultrasound and core kind of getting the cardiac views to globally assess for pericardial fusion and LV systolic function and RV function is VTI. I think it's probably the most useful single hemodynamic measure. And as hopefully we're going to be able to demonstrate, you can use it to phenotype patients' shock extremely, extremely quickly. And in fact, rule out a lot of life-threatening causes of shock with a single measurement of the VTI if you acquire it adequately. And so I'm going to hand this over to Dr. Rikhraj here. But I guess my first question for you is, what is a VTI and why should we use it? And how do we use it? Is it the same as stroke volume, cardiac output? Just give us kind of that intro into the VTI here.
I love it. Okay, I'm just going to quickly share my screen. All right. You guys can
Great.
see it's okay over there?
Yes,
Great.
it's perfect.
Perfect. Okay. So yeah, thank you, Ross. So that's a great question. I wanted to start off with a bit of a review on what the VTI is and what really the premise of it is. And so when we look at this apical 5-chamber view, what we're really trying to figure out is stroke volume. And you can imagine that the LVOT, which is the left ventricular outflow tract, the shape of the LVOT is similar to that of a cylinder. So we're making an assumption that the shape of the LVOT is that of a cylinder. So therefore, in order to figure out stroke volume, all you need to do is figure out the volume of that cylinder. Now, the next slide has a little bit of math on it. I'm going to try not to get bogged down in the details. You can review this later on. You can also check out my YouTube channel for the breakdown of all the math. But essentially, the volume of a cylinder is that of the area of the cylinder times the height. When we figure out area, that's pi r squared. And the radius that we're using is really half of the diameter. So it's half of the LVOT diameter. We won't go into how we measure the LVOT diameter, and as I'll explain later on, we don't really care about the LVOT diameter too much when we're focusing on the VTI and using that as a surrogate for stroke volume and cardiac output. The height of your cylinder is the velocity time integral, which we refer to as a VTI. So putting it all together, you can then figure out stroke volume by getting the LVOT diameter and the velocity time integral. So what really is the velocity time integral? Well, you can refer to it as the stroke distance. So it's the distance that red blood cells travel during systole. You can imagine that at the start of systole, blood is not moving, so its velocity is 0 meters per second. The moment the aortic valve opens and the LV contracts, it causes blood to accelerate through the aortic valve. So rapidly, the blood gains a speed of, say, 0.5 meters per second. At peak contraction or peak systole, the velocity of blood is 1 meter per second. And as systole starts to slow down, you're still in systolic contraction, the speed of blood also slows down. So it goes back down to 0.5 meters per second. And eventually, at the end of systole, when the aortic valve closes, blood stops completely and its velocity is 0 meters per
Kiran,
second.
I'm just going to interrupt. Somebody said that they don't see the slides.
Oh,
Maybe I'll just get a. Can somebody else, just from the audience? So Andrei Kuzmets is not seeing the slides here. I'm seeing the slides. Eduardo, are you seeing the slides?
Yeah, I can see them just fine.
All right. Somebody else can just, if people can just answer into the chat, oh, you can see them. So other people can see the slides. All right, most people can see the slides. Sorry, Andrea, I apologize. This might just be on your end here. So sorry for interrupting here. I just wanted to make sure that we weren't presenting.
Hopefully that got sorted out.
All right, perfect. Yeah. Sorry, Andrea. Good luck. All right, keep going.
So you can imagine that based on this diagram, during systole, the speed of blood varies. And you need to find, well, what was, in a sense, the average speed of blood during the systolic cycle. And so the VTI is really the area under the curve. And when we actually get our stroke volume or our VTI envelope, it's the area under it that tells us what our velocity time integral is. So then what is a normal VTI? Well, the normal VTI numbers that we tend to work with are 18 to 22 centimeters. What I really want to emphasize is that this is based on population averages. And so most people will fall, in normal circumstances, most people will have a VTI of 18 to 22. But your patient might have a slightly different VTI at baseline based on whatever underlying cardiac physiology they have, based on their circumstances, say, whether they're pregnant or not. So their baseline VTI may be different. And I think that's really important to keep in mind when you're assessing a patient in shock. And as we'll talk about later, the change in your VTI is just as important, if not more important, than the absolute number of your VTI. So Ross, you then asked me, well, why should we use VTI instead of stroke volume or cardiac output? And really, this goes back to our equation for stroke volume. Remember that it's based on your LVOT diameter multiplied by the VTI. The LVOT diameter is a measurement that stays constant throughout a patient's lifetime. It's based on your body surface area, which is based on your height. So that's a constant, no matter whether they're 20 years old or whether they're 8 years old. That LVOT diameter does not change. Therefore, a change in a patient's stroke volume is really going to be due to a change in their VTI. So if you have a healthy patient who had normal physiology, was not in shock, and now they've developed shock, they've had a change in their stroke volume, that can only be caused by a change in their VTI. And so really, in my mind, when I'm measuring the VTI, I use it as a surrogate for stroke volume. Similarly, when we go to our cardiac output equation, your cardiac output is your stroke volume multiplied by your heart rate. So now for cardiac output, you have two variables that can change your cardiac output. That's your that's your VTI or your heart rate. And I really want to highlight why it's important to pay attention to the VTI with an example that I've sort of listed here. So say you have two patients who are in hemorrhagic shock. Hemorrhagic shock is a low output state. Both these patients will have a VTI of 12, which is low, and a low stroke volume of 40 mils. But the patient on the left has a lower heart rate or an inappropriately normal heart rate, whether they're on beta blocker, so there's some sort of cardiac pathology, they're unable to generate a higher heart rate to compensate for that low stroke volume. And so therefore, when you calculate their cardiac output, you'll get a low cardiac output of about 2.8 liters per minute. On the other hand, patient B, say is a young, healthy person, is able to mount a heart rate response, and therefore when you calculate the cardiac output, it's 4.6 liters per minute. So this can initially be a bit confusing. You're like, wait a second, they're in hemorrhagic shock, but they have a normal cardiac output. And which is why I think going down to the VTI is important, because that will really help you delineate, well, what sort of shock state they're in. And then it is important to integrate the heart rate and think, okay, is this someone who has appropriate compensation or inappropriate compensation to their underlying physiology? And I think, Eduardo, you had a great point about the minute distance. So I don't know if you want to talk about that as a segue.
Yeah, sure. I mean, that's exactly what you're showing right here. I mean, of course, we care about stroke volume, of which VTI, as you've said, is a surrogate, but heart rate is also important. And then this has been described by Pablo Blanco in the Journal of Ultrasound, who tried to coin this term of minute distance, or what I like to call minute VTI, because it's easier to understand, but we need to remember VTI is just a distance, right?
Mhm.
And so the minute VTI is just doing your multiplication, your VTI times your heart rate. And that will give you a value somewhere between 1,000 to 2,000, right? So a normal VTI of 20 and a heart rate of 100 would be 2,000 of minute VTI. And then that's been studied, and that's been correlated invasively with cardiac index measurements. It correlates very well with cardiac index, not so much with cardiac output. And that makes sense because we are not measuring the area of the cylinder of the aortic valve, which is relying on the VTI and the heart rate. But if you actually think about it, the area of the cylinder of the aortic or the left ventricular outflow tract, that actually correlates with surface area or body surface area. So the larger the patient, the larger the outflow tract, the smaller the patient, the smaller the outflow tract. And so that takes care of that measurement if you are thinking in terms of an indexed cardiac output or cardiac index. And I think that's a more helpful number to try to understand hemodynamics from a quick and dirty perspective doing ultrasound. That would be your normal cardiac index would be a minute VTI of 1,000 to 2,000. And so understanding your patient is in shock and has a minute VTI of 3,000, then that shock is definitely distributed, right? Because there's a high cardiac index. And if your minute VTI is like 500 or 400, then that's a very low cardiac index. And I think it's a very helpful tool. I use it all the time.
And I just want to hop in and say that I use this all the time as well and love it. I haven't measured an LVOT diameter in well over a year for that very reason, that the LVOT diameter is going to be indexed to their body surface area. And if we care about the cardiac index, why not just use the minute VTI? The other thing, and I think Kiran mentioned this, but I just want to kind of double down on it, that any error in the measurement of the LVOT diameter is going to be squared based on the formula because it's pi r squared. And because of that, you can very, very quickly introduce error into your stroke volume just through measurement. And the measurement of the LVOT diameter, although we like to think it's pretty straightforward, there's actually high inter-user variability. And so for our ultrasound fellowship, we measure LVOT diameter, and between even the same person measuring the LVOT maybe 30 minutes apart, you can get vastly different answers. So minute VTI is definitely the way to go.
Yeah. I've seen pretty consistent measurements with minute VTI, so I like it a lot. And I do this as well in my ambulatory patients. I have a clinic where I study patients with AV fistulas who usually have a pretty high minute VTI, and this is what we use to monitor the hemodynamic consequences of having an AV fistula for hemodialysis. So this is not a exclusive thing for shock. I think it's a very universal way to assess cardiac index.
Yeah, totally agree with all those points. And I think that really brings us to, well, how do you interpret an abnormal VTI? And so maybe Ross, I'll get you to answer this and what your approach has been. I have my own approach, I'll maybe hide that, but how do you really approach an abnormal VTI?
So the first is I look at the context, and with HCP rounds, one of the things we always kind of focus on is let's start at the microcirculation or the end organ perfusion first. So I'm going to assume that we're talking about a patient with abnormal perfusion, shock of some sort, and we want to figure out why do they have organ failure? Why do they have shock? And so I start with the VTI as my first decision point. Because if the VTI is high, or more specifically, if the minute VTI is on the high side, so we have adequate cardiac index and the patient's in shock, then we can almost rule out a few different types of shock. So patients with cardiogenic shock have low minute VTI. Patients with hemorrhagic shock, patients with obstructive shock from a PE, once you've ruled those out, really what you're left with, if you have a high cardiac index or a high minute VTI and shock, is distributive shock. And so very quickly you can kind of break them apart and figure out which category of shock we're dealing with. Now, if you have a patient that has distributive shock and has a high minute VTI, it also helps dictate your treatment a little bit. I typically don't give a lot of fluids to patients who already have a high VTI, because the purpose of giving fluids is to augment your VTI, to make it go higher. But if it's already high, and if your minute VTI is already high, what are we going to accomplish by increasing that stroke volume even further? And so often on those patients, I might even take an approach to use vasopressors preferentially over fluids in that exact population. And so that's kind of how I use it to break down my initial approach to shock. And another good example is, say you have a patient with a pulmonary embolism that's complex. They also have sepsis. They have a lot of stuff going on, and you're trying to figure out, is this patient dying of RV failure in front of you? If your VTI, and you're measuring it correctly, is 28, the short answer is no. If you're dying of obstructive shock, your VTI will be low. And I just find it so useful to reassure me that no, you don't need to give thrombolytics to a patient with a VTI of 28 with a query obstructive shock, because that's not the cause of their hemodynamic compromise.
Yeah, and I totally agree with that. And really, when I think of a high VTI, in my mind, I'm like, there's less resistance for the heart to pump blood out. So I think of it really as a low LV afterload state. And that can have multiple different reasons, as you've described, whether that's sepsis, vasosplegia, anaphylaxis, acute liver failure, all the other sort of causes that are listed here. And so I think that's really, as you said, the big distinguishing factor when you first measure the VTI. Is it high? Is it low? And really, when you have a high VTI, your differential diagnosis is pretty narrow. It's mostly distributive shock. I'm curious, Eduardo, do you have the same approach? Is that really your first branch point?
Yeah, I mean, it varies. Depends on whether I'm doing a crit care or I'm doing nephrology. It's very different. So if I'm approaching shock, which I sometimes I'm on the primary team, then yes, the main decision point would be, is this patient with hypoperfusion, having a very low cardiac index, and then that could this explain the hypoperfusion? And then of course, if minute VTI is high, then you're kind of in an easier pathway to make a correct diagnosis. Now, if your minute VTI is low, then I would say that's a little harder, because the most frequent cause of shock that I see in my center, which is a medical ICU, is sepsis. And then sepsis, it could very well explain it, right? So sepsis can cause a high VTI because of low afterload, but then usually sepsis can also, or more frequently in my experience, would lead to a very low VTI because of venodilations and third pooling and capillary leak, and then that your low min systemic filling pressure. That's a fantastic slide. And then of course, what do you do with a low VTI in sepsis? Does that really need, is that a goal? Should I normalize it, or should I go and go all the way and just do like my friend Glenn Hernandez in Chile, maybe care a little bit less about the VTI and care more about my capillary refill time, and then that increase my vasopressor, and then maybe that takes care of the problem. And that I think the answer to that will go into assessing your cardiac function. So if I have a patient with sepsis who has a normal ejection fraction or hyperdynamic heart, I don't see a significant alteration, I don't see RV failure, then I think that low minute VTI it shouldn't be taken care of. And what I need to take care of what I need to treat is sepsis. So source control, early vasopressors, and then just titrate the vasopressors and maybe a little bit of fluid resuscitation to capillary refill time.
Yeah, and I want to give a shout out to Dr. Corbin Haycock for the slide. This is his excellent slide that he's very generously shared. So, but you're absolutely right. Yeah. Ross, did you have something to add? I think you wanted to mention something about that.
Yeah, I think one of the other uses of VTI is trying to figure out whether or not a anatomic or structural problem is cosmetic or culprit. And so when you have patients that are in the ICU with septic shock, many of them will have LV failure, either acute or chronic. Many of them will have RV failure, RV dilation, acute or chronic. And in these complex hemodynamic patients, it can be really difficult to figure out, is the LVEF of 40% cosmetic or not? Or is it actually driving the patient's hypoperfusion and shock? And to me, the VTI is the ultimate arbitrator of that. You can spend a lot of time with POCUS over rotating and all these different things, but at the end of the day, if your VTI is adequate, chances are the what you're observing isn't causing the patient shock. It's probably or potentially a bystander or not the sole driver of that patient's hypotension. But if the VTI is 6 or something like that, then yeah, you need to really figure out what you can do to fix those.
Yeah, I totally agree. And I'm curious, how do you then break down your approach to a low VTI? Do you have an algorithm in your mind on how you break that down?
I use the traditional kind of groups of shock, kind of combining the rest of the echo. So I would look at kind of, so I don't have as I don't necessarily use this physiologic one, although it totally makes sense. I just think of it more like it's obstructive, cardiogenic, or kind of low mean systemic filling pressure, which could be due to hypovolemia or it could be due to venodilation. But tell me about your approach, Kiran.
So my approach is very similar to yours. I just kind of take a step back, and for me, it's easy to think, well, the cardiovascular circuit, it's a pump and there's pipes. It's pump and pipes. And so that's how I really break it down. Well, for me, when I think about a low VTI, the two biggest things I think about is, well, there's just not enough blood getting to the left ventricle. And I'll specify why it's important to think about not enough blood getting to the left ventricle, not just the heart. The second thing I think about for a low VTI as well, the LV is receiving an adequate amount of blood, but it just can't pump it out adequately through the aortic valve. And so when I talk about, well, there's not enough blood getting to the LV, I think of it as a low LV preload. And this can really, in my mind, be broken down into two things: your classic hypovolemic shock or your classic obstructive shock. And so on the left side, when in hypovolemic shock, you just don't have enough blood in the body in general. So therefore, you're not going to get enough blood to the LV. This can be due to bleeding, GI losses, insensible losses, whatnot. On the other hand, in obstructive shock, classically, you have enough blood in the body, but that blood is, being blocked somewhere and it just can't return to the left heart. Whether that's because there's tamponade, you have diastolic insufficiency and blood can't get back to the heart, or you have RV failure where the RV just can't pump that blood to the left heart. Tension pneumothorax, abdominal compartment syndrome, et cetera, et cetera. And really, I've sort of grouped the low mean systemic filling pressure is a type of distributive shock. But again, as we sort of already chatted about, blood can't get to the left heart. So it's a distributive shock, but it falls under the low VTI category. And that's how I really break it down in my mind, because I think of the pump, I think of the circuit and the blood flow. And you can sort of relate it to then hypovolemic, obstructive, distributive, et cetera, et cetera.
I think that's fantastic. And I think that one always that's scenario that's hard to take care of is you're assessing shock, you're doing your VTI, and you get a normal value. So then we're always talking about, what do you do with a high VTI? What do you do with a low VTI? Then what do you do with a normal value? And if you let me, I think the first thing everybody should know is, fixing the VTI or getting it to a normal value is not the goal. The goal is organ perfusion, right? And then, if you're just focusing on this value and trying to get it to normal, then you might, just over-treat or over-resuscitate. Don't try to get the value back to normal unless you have a good reason to do it. And that would be a low capillary refill time, maybe oliguric AKI, together with other signs of hypoperfusion, right? And then maybe if your patient is crashing. But then, of course, I think whenever we decide to treat a patient with an altered VTI, whether it's be high or low, then don't focus on the absolute value. But then, if you have a patient who's hypoperfused with a low VTI, and we've decided this VTI needs to be maybe a little bit higher so he can get better perfusion, then trending your VTI here, just like your slide says, the change in VTI will be a more important monitoring tool than the absolute value of either your minute VTI or VTI. Wouldn't you agree?
Yeah, I totally agree. And I think that really brings Ross's point to the forefront, where how much of the LV dysfunction that we often see in, say, septic cardiomyopathy is a cosmetic issue rather than something that's causing ongoing hypoperfusion. And I've definitely had circumstances where you see that depressed LV systolic function, they're in shock, and you say, okay, like I'm going to start an inotropic agent. And I've had recently a good case where it dropped my VTI rather than improving it. And that in my mind, well, that's not the issue, right? It's not a pump issue that's causing my ongoing shock. I have other parameters that I need to correct and improve my patient's end organ perfusion. And so I think this slide also really highlights that every time you get your VTI, it's hypothesis generating. You're going to use your approach, whatever that might be, whether it's a physiologic approach or a classic sort of shock categories approach, to come up with a hypothesis as to why your patient is hypoperfused. And then you're going to start an intervention. And the key thing is always to monitor the effect of that intervention. Has it had the effect that you wanted, or has it actually had the opposite and your hypothesis was wrong? Go back to the drawing board.
Yeah, that's great.
All right. Well, maybe we've talked a lot about the theory behind VTI. There's certainly some practical applications, pearls, pitfalls. Kiran, why don't you just walk us through a couple of the considerations? You show up at the bedside, you're going to do a VTI. How do we get the best VTI possible so that we can actually make decisions on quality measurements?
Yeah, totally. I think the first thing that I want to highlight is that maybe the difference between pulse wave Doppler and continuous Doppler. So why are we using pulse wave and not continuous wave Doppler? And this goes back to ultrasound physics. We won't get too much into the weeds of this, but really when you think about pulse wave Doppler, the ultrasound probe is sending out a sound wave and it's waiting for that sound wave to come back. It will then calculate how far that object is and how much, based on how much time it took for that signal to come back. So when you're using pulse wave Doppler, it can measure the velocity at a specific point, which is the point of your interest. And when we talk about VTI, we really want to know the speed of blood at the LVOT, which is just proximal to that aortic valve annulus. The important thing about pulse wave Doppler is that it is limited by speed. So it can only really accurately detect speeds of about 1.8 to 2 meters per second. Anything beyond it and the pulse wave Doppler signal, I like to say, gets confused and it cannot accurately detect the speed and the direction of blood flow. On the other hand, on the right-hand side of the screen, you have continuous wave Doppler. So in this circumstance, the ultrasound probe is continuously sending out waves and it's continuously receiving those waves. So it can track infinite velocities because it's continuously listening for any sort of bounce back of those sound waves. The problem is that you don't know at what point those sound waves are coming from. So when you have a continuous wave Doppler line, the velocities along that line are all being tracked. So you have no idea, okay, is my velocity at the aortic valve? Is it at the LVOT? You don't know, which is why it's really important to, the first thing, anytime you're doing a VTI, make sure you're on pulse wave Doppler, not continuous wave Doppler. The next thing is positioning. And positioning is really key. So where you place your pulse wave Doppler signal will affect the shape of your LVOT envelope, your VTI envelope, and it will also affect your speeds. And really, you want to place your pulse wave Doppler signal just proximal to the aortic valve annulus. The way you'll know this is that you'll get this closing snap of the aortic valve, but not the opening of the valve. So the closing of the valve, this is your VTI envelope. The closing of the valve is that bright line right here at the end of the envelope. You want to see that. If you had the aortic valve opening, you'll see another bright line just before the envelope. Now, if you get that, that suggests that your Doppler signal is too close to the valve. You can imagine that the aortic valve is an area of narrowing. So as blood approaches the valve, it accelerates. And so if you get that sharp sort of spike before your envelope, you're too close to the valve, you're actually going to be overestimating your velocities. And so this is really key. Anytime I'm doing any VTI measurements, I make sure that I place my pulse wave Doppler in the correct position. I check for that closing snap. I make sure I don't have that opening. The next thing you want to ensure is that you have a clear envelope. So as you can see from this image, this is a pretty crappy envelope, right? Yeah. The prior image, you had that really nice spectral envelope. You had central clearing, which is what you want to look for. In this one, you have no central clearing. And so the key premise when you're measuring the VTI is you want to get the modal velocity. So you want to capture the velocity that most of the red blood cells are flowing at. When you get an envelope that's messy like this, it suggests one or two things. It suggests that there's turbulent flow, or you've actually measured it wrongly. You've positioned your pulse wave Doppler wrongly, and this will lead to inaccurate measurements of your true VTI.
I'll just make one comment. The most common cause that I see for this is that the Doppler angle is just not well enough aligned with the LVOT. If you measure any LVOT at like 30, 35, 40 degrees, you get this envelope. It's extremely difficult. Oh, wow.
There you go.
Sorry.
That's a perfect
Didn't mean
segue.
to,
No, I
didn't
love
mean
it.
to beat you to it here.
No, I love it. So exactly as Ross was saying. So we call this the angle of insulation. The more parallel you are to the flow of blood, or sorry, the more parallel you are to the direction of blood flow, the more accurate your measurement will be. We call this the angle of insulation. So where your pulse wave Doppler signal has a certain angle and the direction of blood flow has a certain angle. And you want that angle to be less than 20 to 30 degrees, ideally less than 20 degrees, because that will give you a more accurate velocity. The further away you are, or the greater your angle of insulation, you're actually going to underestimate your VTI, and that's going to have implications for your hypothesis as to what your cause of shock is, et cetera, et cetera. I then want to talk about taking multiple VTIs. And this is important because there are some variations at times from beat to beat from your VTIs, particularly in patients who have arrhythmias like atrial fibrillation or other arrhythmias. Your VTI can actually vary beat to beat. And the recommendation is to take, in someone in sinus rhythm, at least 3 VTIs and take the average of those VTIs to get your true number. In someone who has an arrhythmias, you want to take at least 5 or more VTIs and average out those numbers. Sometimes you also notice your hand might slightly, it's hard sometimes getting that apical 5-chamber view. Your wrist is going to just move a little bit. You might make an error. So this is why I often, when I'm teaching trainees and people who are learning POCUS, I said, just focus on the technique, take multiple VTIs, make sure you have a really good envelope, the closing snap, et cetera, then take your average and integrate it. I'm curious if you guys have any other tips for this.
No, but the literature also suggests that even the same individual making a VTI measurement on the same patient 10 minutes later, there's about a 15%, up to a 15% variability in VTI based on patient positioning, probe positioning, just kind of technical factors. And so I think averaging multiple ones is a great idea, but also recognizing that when we say to look for changes in VTI, we're not talking about the VTI went from 8.2 to 8.7. To me, those are the same values. We're really looking for trends that are bigger than that. So like a VTI going from 8 to 10 to 12 to 14, that's probably a significant change. But kind of within 1 or 2, I typically don't view that as a meaningful change given the wide kind of confidence intervals surrounding the exact value based on measurement error.
Yeah, and I think that strategy of taking multiple and then just averaging them to get a correct measurement is what I mean. This is this is a standard thing. I mean, if you are reading the American Society of Echocardiography guidelines for atrial fibrillation, they tell you to get 5 to 10 heartbeats and average them, and that applies to everything that's a variable. I'd say I do the same thing for patients who have a lot of motion with their cardiac windows with respiration, and you're not sure whether this is really a respiratory variation in minute VTI or in VTI, whether just an artifact of respiratory motion of the LVOT window, and then getting 5 to 10 heartbeats and averaging them out will give you a pretty accurate value, I think.
Yeah, I love it.
There's a great question in the chat about pulse wave Doppler angle correct. Do either of you use angle correct when you're measuring VTI, and why or why not?
Yeah, that's a great question. I don't. There have been some studies that show that the angle correct is a function of the actual machine itself. And because of the 3D nature of blood flow, it's not as accurate as one might think. So if you actually go back to the American Society of Echocardiography guidelines, they recommend against using angle correct. I think this is really where perfecting your technique comes in. So it's a lot of practicing and playing around with your angles, particularly in that apical 5-chamber view, maybe rocking your probe side to side to get that perfect angle as best as you can.
That's correct. And I think I've seen many patients who are many residents and fellows who are beginning their training in ultrasound, and they are tempted to do angle correct. In my experience, it usually overestimates the VTI by a significant amount if you do angle correct. And once you get good at getting a good apical 5, and as you said, rocking the probe to align the LVOT to your probe, you'd see it's very rare that you don't get a good angle for VTI if you're doing transthoracic echo, right?
And maybe I'll just add one more thing. I totally agree. I never use angle correct. The reason why is angle correct is a mathematical correction based on the like kind of variation in angle, but it doesn't account for the fact that when you acquire a VTI measurement off angle, you run into the issues that Kiran was saying where not all of the blood is moving at the same modal velocity. And so you are now essentially doing angle correct on a VTI measurement that is not actually a laminar group of blood, a column of blood moving at the same velocity. And so you haven't addressed that factor, that when you measure at 30 degrees, your VTI isn't accurate to begin with. So you're correcting an inaccurate VTI essentially. And so for that reason, totally agree. I don't use it.
Yeah. And perhaps we can chat a bit about, well, what views do you use to get a VTI, whether transthoracic or transesophageal? And when you are encountering a patient who has, say, a difficult view in one modality, what is your approach? Maybe Eduardo, I can hand that off to you.
Yeah, can you repeat that question, Kiran? I was answering one
So I was
of
going
it.
to say, so perhaps we should briefly chat about, well, what are the views that you use in both transthoracic versus transesophageal to get your VTIs? And if you are having trouble in, say, the apical 5-chamber view, do you have any other strategies on how to optimize that?
Yeah, well, I don't do transesophageal, so I am stuck with the transthoracic. And I think if I can't get a good apical 5 to get a VTI, then I'm kind of stuck. I've tried to do this in getting a VTI from the subxiphoid, and this has been described, and you can do it, but I find it very hard to get a consistent and reliable and reproducible VTI from the subxiphoid, and the angle is not the best. So what I do is, and I think you are a supporter of this, is if you can't get a left ventricular stroke volume, then you might try to assess your right ventricular stroke volume. And in most people who don't have a very dilated pulmonary artery, then these values should be very similar. Maybe the RVOT VTI is a little bit smaller, but what goes in the right heart must go to the left heart, and this is a closed circuit unless there's a big shunt between your right cavities and your left cavities. Then that may be a difference. But ignoring your congenital cardiac patients, your RVOT should be almost the same as your LVOT VTI, and then sometimes it's very easy to get a good window for the RVOT VTI, even from the subxiphoid view, and that can definitely give you a good surrogate of cardiac index or cardiac output, and then you can of course trend this value and not take it as an absolute measurement.
Yeah,
I don't have anything to add to that. Totally agree.
Yeah, and I think that really, as Eduardo said, it highlights the utility of the RVOT VTI. So what I've really displayed here in this image is a subcostal short, where you've fanned towards the left side of the patient's body, and you're actually able to get the RV at the top of the screen here. That's the tricuspid valve, the papillary muscles of the RV, and this is the RVOT, and your pulmonic valve sits right here. So you can see from this image that your blood flow out of the RV into the RVOT and the pulmonic valve is quite parallel to where you can place your pulse wave Doppler signal. So you get away from that, okay, I have issues with my angle and the direction of blood flow. You're able to get, most of the time, this beautiful RVOT VTI tracing, which you can use with a similar approach as your LVOT VTI. And as Eduardo was saying, your numbers are slightly different because typically the RVOT diameter is slightly larger than the LVOT diameter. The cardiac outputs are the same. What goes out of the the right heart must go out of the left heart, unless you have a big shunt or severe, AI or pulmonic regurgitation. But typically the cardiac outputs are the same. And so usually the numbers that I have in my mind for an RVOT VTI is about 14 to 16 centimeters as the VTI. And you measure that number, you use that same hypothesis generation of your approach to an abnormal VTI, and then you track your changes in your number. So I really like this as a strategy for transthoracic ultrasound if I'm unable to get an LVOT VTI.
Yeah,
Love
that's
it.
great.
I guess one of the last things that we have to talk about with VTIs, what do you do when you see a lot of VTI variation? Sometimes this can even be like exaggerated VTI variation. Any thoughts on how you approach this? Does this mean the patient's fluid responsive? Is it the same as pulse pressure variation on a art line? Just curious what people's thoughts are here.
Yeah. Well, I think it's funny that you mentioned it because I mean, I was just talking about this a minute ago. When you have a lot of variation, what do you do? What's the normal? What's the real VTI? And you're right. This might be a real phenomenon happening to the patient, that he has a variation in stroke volume, beat to beat, because of respiratory changes in intrathoracic pressures. And then it's usually, when I've seen this, is it's usually a sign of severe hypovolemia, or I mean, I shouldn't say hypovolemia, a low mean systemic filling pressure, or a severe dysfunction of your RV. But sometimes this might actually not be a true phenomenon, right? This might just be an artifact of motion of your cardiac window with a very heavy breathing. There's some patients where they breathe and their cardiac window just moves, and then your gait or your sample volume would be in a different position with respiration changes, and you'll get different VTIs. And how to distinguish between those two, I think it's more like more an art than science. But you have to see the 2D image where your gait is positioned, whether there's a lot of motion of this VTI in concerns or in regards to your sample volume. And if you think this is a true respiratory variation in stroke volume, then yes, you need to think that your patient has respiratory variations in stroke volume secondary to either low mid systemic filling pressure or severe RV failure. Of course, this can also be cardiac tamponade, and that's for you to figure out. How do you assess cardiac index in these conditions? I would apply the same strategy as your patients with atrial fibrillation. So let's get 5, and I would say 10 heartbeats to kind of get an average stroke volume for this patient. And of course, recognize the fact that there is a real respiratory variation, and that's another piece of information that you just got from this patient, whether he's fluid responsive or whether he has RV dysfunction. What do you think, Kiran?
No, I love that approach. I think you just have to be really mindful, as you said, about, well, what is causing my variations in the VTI? And one of the strategies that I like to use that we put here is actually decreasing the sweep speed. So that's how many VTI waveforms you can get on your screen. As you can see here, typically you want to have, as few envelopes as you can so you can more accurately trace it. But in a circumstance like this, where you're debating on whether there's respiratory variation, you actually want to get more of those VTI waveforms on that strip of paper on the ultrasound screen so you can visualize if you truly have respiratory variation. What can sometimes be really helpful is that there are some ventilators that can actually be hooked up to the ultrasound machine, so you can actually see, well, is it during inspiration that I have my drop, or expiration, et cetera, and that can really drive your differential diagnosis forward on, well, what is the cause behind this?
Yeah.
And then perhaps, oh, sorry, go ahead, Eduardo.
I was saying I love that.
Perhaps one of the last things to chat about, and maybe I'll give this to you, Ross, is, well, how does the shape of the LVOT tract influence your measurements? Because I think this has come up somewhat in the literature and some discussions as well.
Yeah, so this is a canonical debate first of all, none of us measure the LVOT diameter, probably in part for this reason. And we, again, focus on something like a minute VTI, where you're looking at the VTI and the number of VTIs in a minute as a surrogate of stroke, of cardiac output, or sorry, I should say cardiac index. But if you are going to measure the LVOT diameter to give a stroke volume and a cardiac output, you have to be aware of the fact that we make an assumption that the LVOT is perfectly cylindrical. And that is true in 22% of the cases, at least based on this study. But actually, a lot of them, there's a more of an hourglass or even a funnel shape in the minority. And it actually turns out that depending on the shape of it and where you measure it, you might overestimate or underestimate stroke volume. And so my approach, if I am going to measure the LVOT diameter, in a perfectly cylindrical LVOT, I will try to measure the LVOT diameter about 0.5 centimeters, 5 millimeters on the kind of ventricular side of the valve. And that's typically where we're going to be placing our PW gate, so it all makes sense. In the case of these other hourglass or funnel shaped, I will often measure my LVOT diameter right at the base of the aortic valve. And there might be an echocardiographer listening to this who's going to kind of lose their mind about this, but this is an actively discussed and debated and researched area of the field. But you can see, even just based on the variability in shape here, measuring it in general has so many potential limitations that it just isn't really worth it to me. Because you can either overestimate, underestimate, or just frankly measure the wrong LVOT diameter based on the shape of the LVOT, which is not cylindrical in most patients. Yeah.
Totally agree with that. And I think it also then goes back to our point of, well, why do we just use the VTI? Why do we ignore that LVOT diameter, right? So, and if you're measuring it consistently, your LVOT VTI should be reliable and you should be able to measure the changes in that. And that should really influence your decisions more so than, pi r squaring a false number.
That's right.
Awesome.
I would like to take just 3 more minutes before we wrap it up, because I just remembered a case where I think VTI was a significant contributor to bad outcome of a patient. And I had a patient with severe sepsis. She was an old lady who happened to have an anatomical variation that's usually seen in old females, which is a little bit thicker interventricular septum than the rest of the heart. And this was not a hypertrophic cardiomyopathy. This was just a sigmoid shaped septum. And because of the severe sepsis and the hyperdynamic state, this sigmoid septum was causing obstruction of the left ventricular outflow tract. And of course, when you do a VTI with pulse wave Doppler, and you have obstruction, you have a very turbulent flow, and we've discussed this in our podcast with Katie Whisker. And you have different dagger-shaped VTIs, but you might not recognize this if you do pulse wave Doppler, because you will just see a lot of turbulent flow, just like the examples you showed before, Kiran. You really don't have a good model velocity, and the ones that were in charge of this patient were measuring the VTI, and they were getting values closer to 28, 29, and so they were very certain that they were dealing with a distributive shock. And because the patient had severe sepsis, they just keep pumping on more vasopressors, and this were norepinephrine, and we all know that LVOT obstruction worsens with norepinephrine. And I'd say they were relying on a poorly acquired VTI that didn't have a good model velocity, but then they also ignored a significant clinical finding that was present. This patient had a pulse pressure of 20. So how can you be certain this patient had a distributive shock with a VTI of 28 and a pulse pressure of 20? That made no sense to me. And of course, Corbin is here, and he would talk all about pulse pressure and about the determinants of pulse pressure. But I would say pulse pressure can be increased because of things that have nothing to do with hemodynamics and have to do with stiffness of your arteries. But a low pulse pressure in an 80-year-old patient is a very, very likely that this patient has low stroke volume, because there's not a lot of causes of low pulse pressure, especially in elderly patients, where you would expect them to have arterial or calcification, and their baseline pulse pressure should be a little bit higher. And so it turns out this low pulse pressure was because of low cardiac output, because of obstruction, and then the treatment was completely wrong. And I think just relying on a single value was the mistake. But then even if you're relying on in a single value and it's not perfectly obtained, and then you're ignoring other clinical factors such as pulse pressure, then you're going to get in trouble. And of course, this is what POCO says, just another piece of the puzzle.
Beautifully said. Awesome. Great. Well, Kiran, I'll give you final words here. Any last things you want to leave the audience to think about?
Yeah, I think the key things are first recognizing that the most important value probably that you can measure, in my opinion, in any patient in shock is the VTI. but also knowing all the caveats that come with measuring the VTI and recognizing that while the absolute number gives you a hypothesis on your cause of shock, you need to test that hypothesis out. You need to start interventions for that patient and measure the changes in the VTI. So I think that's probably one of the most important things that I want to leave people with. The second is refining your technique. And this is something that I find when you're starting out, and I know for myself, when I was starting out, I tried to rush it, right? I was like, that's good enough of a, of an envelope. I'm going to take that. I'm going to trace it. Oh yeah. So what if I have my aortic valve opening? And it's tempting to do that, but you're doing yourself a disservice, you're doing your patients a disservice. So really work on refining the technique. There's a lot of literature, there are a lot of videos out there on, what an appropriate envelope is and how to measure it, et cetera, et cetera. So do your patients that service, do yourself that service in getting good at it, and then you can go forward and rely on those numbers and make adequate clinical decisions. And the last thing that I want to leave, and I think is, Eduardo said it and highlighted it perfectly, is integrate that value with your patient's clinical context. The number is a piece of the puzzle. You should not just rely on it on its own. You have to take into account what's going on with the patient, both from a macro hemodynamic level and a micro hemodynamic level, and use that to help your patients going forward. So yeah, and finally, thank you, both of you, for having me on the podcast. This was really fun.
That was you were fantastic. Thank you for being with us.
Thank you.
Yeah. Thanks, and I'll see you guys both in Montreal in May, and maybe we'll have to do a live recording or two. It could be a lot of fun. It'll be better than the last one we did, where we ended up drinking too much beer, and then things just kind of devolved. So we'll aim for a better one this time.
The actual conversation was pretty good, but the problem was Russ's microphone was not.
yeah. Didn't
we'll
work
have
well.
a ping pong tournament, and then you guys can duke it out.
I love it. All right. Thanks everyone for joining us.
Thank you.